Yes, ma'am, we are live.
Can everybody see my slide?
Yes, ma'am.
Okay. Am I visible? Hello? Hello? Yeah. Please start. Seema?
Yes, ma'am.
So, good evening, everyone. We missed conducting a webinar in January 2025, but it is a pleasure to have yet another webinar to discuss myeloma and kidneys in the month of February. We are committed to keep our webinars going in the coming months also. This month, we have Dr. Shaila Khubchandani ma'am to discuss myeloma and kidneys. Like I was discussing with ma'am, I've been seeing her reports since a very long time, and probably even a time when I was in school and I didn't even know anything about medicine. It is a pleasure to have you, ma'am, and we welcome you to Nephrocon. Today, we will be discussing myeloma and kidneys. There is a lot that has transpired over about the myeloma spectrum in the past 10 years. And without much ado, I just want ma'am to do the honors about discussing this topic. Over to you, ma'am.
Okay, so thank you so much, Purva, Dr. Mahesh, Dr. Girish, for inviting me for this. And I always tell everybody that you're taking a chance when you invite first a lady and secondly, the one who likes her kidney biopsy so much. I may not stop. But anyway, so let me begin. I just wanted to first check with you if we have any of our junior colleagues with us, who are maybe going for a DNB or anything like that. If we don't, I'll just jump into the whole story myself.
And we have two forums, like two platforms. The one on Zoom and the other one on YouTube. But there are students who join the program. So
okay, so in case there is anybody here, I'm just going to go straight away. So just a minute, let me go on the. Yeah. So I'm going to start with a story of a 49-year-old male who basically had hypertension for almost 5 years and was on treatment. He had severe, GI issues. And so it was decided that he needed to go in for a hiatus hernia surgery since he had GERD. But he wasn't a diabetic. When he was sort of evaluated prior to his surgery, they found the creat at 1.6, and that immediately raised alarm bells. Proteinuria was 2 plus, and the 24-hour urine protein was at 2652 milligrams. They started him on some therapy and said, we'll reassess the situation at 3 weeks. And in fact, they found that the creatinine could be, of course, possibly error of laboratory, but it was almost the same at 1.55. So I just wanted to know if any junior person is here as to what he or she would like to have done after this. Okay, so I'm just going to continue. This patient was.
I would like to do a biopsy for this gentleman.
Absolutely.
Because the proteinuria is more than 500 milligram. We don't know the native kidney disease.
Correct.
And apparently he came into picture for some other reason, like non-nephrological. It was a GI problem.
Absolutely.
So I would definitely try to do a biopsy.
And the thing was, he just came for a pre-op, test, and he was shocked to find all this. And so the examinations were all, as I've shown you over here, almost near normal. And just that every time what troubled was this BUN creatinine levels. And so, of course, our nephrologist in Jaslok went ahead and did the biopsies. And this is what we saw. So any suggestions or ideas or anything like that for these gloms?
Nodular.
Yes, very good. So it definitely has a proper lobulated pattern. You can see that there's eosinophilic fibrin material which is present in the area where we should have had a normal mesangium. There is definite basement membrane thickening. And I want you to appreciate that it has this little glassy, waxy appearance. And so you have to therefore move forward to do some specific tests. Please note the PAS stain. If it was just some sclerosis or if it had been a diabetic nephropathy, which may look identical, an absolute mimic, and you won't be able to separate, most often the PAS would come shining back at you quite bright. And you can see here that this was probably some extraneous material because the silver has completely negative and it's green all over. Now, Congo red stains, as you can see over here, are strongly positive, and you can see this apple green birefringence, avocado green, whatever you'd like to call it. And I always wonder why pathologists have likened everything to food, but I think they have a lot of time, that's why. And this is the picture that you will see on immunofluorescence, which is a salmon pink appearance. So then this in itself gave off the diagnosis that this is definitely amyloidosis involving the kidney. And like Purva said, about 20 years ago, I would have just stopped at this, felt very proud of myself to give such a spectacular diagnosis, and I've kept quiet. But we have to move on, and you have to do the immunofluorescence. And the reason to do this is because there are very few amyloids as of now, which at least we can control. The secondary ones, of course, if we know the primary disease. But this is one of those which we would like to know about, because there are some measures, as our oncologist colleague who's here would like to tell us in time to come. And sure enough, what I got was strong lambda positivity in the regions of where the amyloid deposits were, and a completely negative kappa, suggesting that there is a lambda deposition and no kappa. So letting me know that there is light chain restriction and therefore monoclonality. So therefore, this is amyloidosis resulting out due to the presence of monoclonal deposits of some part, whole part, subpart of the immunoglobulin. It's always good, and I never, ever, ever stop to emphasize to please keep a bit aside for electron microscopy. We are capable of now converting the paraffin block tissue to it, but the tissue distortion is so enormous that it's always nicer to have it. If you got your diagnosis in the combination of the first two tests, you need not do it. And the tissue you wasted is the size of half a rice grain or a sago seed. So you don't have to feel bad about it also. And we can always convert it to a light microscopy. And what you do get at electron microscopy is the same. You find the deposits in the mesangium. You can see one loop here, another loop here, the epithelial cell here, another epithelial cell here. And this is the mesangium that I'm looking at high power. You can see the fibrils, and they have to be bordering around the number 10. So it's very easy to remember. It could be just a few nanometers below or a few nanometers above. Now, most often, the amyloid deposits will start in the mesangium and then graduate because they overflow, because they completely overshadow the whole glomerulus, and then they come into the basement membrane, and you can see it over here very nicely. There are very few diseases where they start first in the basement membranes. Now, therefore, naturally, when you show monoclonality, this patient was eventually, subjected to the whole gamut of investigations specifically. And in this day and age, now they're available so easily, that serum electrophoresis was done. And most important for me to emphasize over here that there was no M band, if you can see over here. So now here we have a situation where we have a categoric monoclonality, but no M band. And this is what I want to emphasize about amyloidosis. It may not come with a classic M band, but if you notice over here, you will see that the light chain levels are definitely significantly raised, as is, of course, the kappa, because there is some degree of tubular damage. So you have both the light chains coming out, but definitely far, far greater for the lambda. And this is what a large number of the amyloid deposits do. They do not initially present to you with a clear-cut signal of a significant increase in the amount. So you have to understand that the electrophoresis also has a limit, and the lesser the immunoglobulins, the light chains that you have, they may not show out right up front in the electrophoresis. So I'm just going to straight jump into what is monoclonal gammopathy. And it's basically just the monoclonal immunoglobulins in the serum or in the urine. And when I mean clonal, I mean they've all come from a single cell. And they could be plasma cells, they could be plasmacytoid lymphocytes, or differentiated B cells, all under the heading of the B group lineage. Now, in 1978, Robert Kyle found something where the levels that he found were less than 30 grams, and the number of plasma cells that he got was less than 10%. And he found that they were not causing any organ damage at all. And so he decided to label this condition as an MGUS, that is, monoclonal gammopathy of uncertain significance. However, if the levels of your monoclonal immunoglobulins increase and then they start causing organ damage, then we know that they've already crossed the limit. And we have these three conditions that we get, which could be multiple myeloma, Waldenstrom macroglobulinemia, and chronic lymphocytic leukemia. It's important to remember that all immunoglobulin conditions will involve the kidney, because the eventual excretion of this is through the tubules and are therefore going to affect the kidney in some which way. Now, as I mentioned earlier, the could be due to the presence of the heavy chains, the breakdown product of the immunoglobulin, light chains, combined heavy light chains. They could be in the serum only, or in the serum and urine, or sometimes only in the urine. And we have various ways of determining these immunoglobulin whole or byproducts. Now, if there is renal involvement and if the clone is not malignant, by that I mean that it is below a certain level and the plasma cells present in the marrow are below a certain level, it is termed as monoclonal gammopathy of renal significance. And the definition is that it is these breakdown products or the entire immunoglobulin which has resulted in the renal lesions, and they are of monoclonal in origin. So what are all these conditions? And that is the reason why I keep emphasizing you do need the EM for this. We can classify them as organized deposits, or we classify them as non-organized deposits. non-deposit associated lesions. And then as usual, when they don't fit into anything, we like to just group them together in a basket of miscellaneous. So here we go, our organized immunoglobulin deposits, if they have a pattern of fibrils, like we have in the amyloid deposits, then they are called as amyloidoses. If they have a tubular pattern, then it's immunotactoid or cryoglobulins. Sometimes they can precipitate as crystals, and then we have the light chain proximal tubulopathy or the crystal-associated disease, which could involve the macrophages, and then you can have the crystal-associated cryoglobulins, or you do have a light chain crystalline podocytopathy. Now, in the non-organized deposits, you have the monoclonal immunoglobulin deposition disease. You have the proliferative glomerulonephritis with monoclonal deposition and the miscellaneous group, which I'll just come to in a point in time, but it could be membranous where the PLA2R is monoclonal. It could be HSP or IgA. Sometimes there is no deposit, and then it has been shown that the patient does have increase in the levels of a monoclonal immunoglobulin, its breakdown products, and can be associated with C3GN, a thrombotic microangiopathy, or anti-GBM antibody disease. So you can see, like what Purva said, that the spectrum has really grown. And it's always nice to remember which is the part of the glomerulus that it involves greater in amount than the other, because that's how the patient is going to manifest to you clinically. So if the patient has immunotactoid or fibrillary, that means if the patient has come with amyloid deposits or immunotactoid or a fibrillary GN, then definitely the glomeruli get involved and proteinuria becomes the most important presenting feature. Proliferative GN with monoclonal immunoglobulins also comes to you with nephrotic range proteinuria, but in addition may have a nephritic picture because it is a proliferative GN. When you have a cryoglobulin, which is monoclonal type 1 or type 2, then along with the gloms, the vessels are involved. With amyloid and monoclonal immunoglobulin deposition disease, all the three components, sometimes even the interstitium is involved. Glomeruli with interstitial involvement happens in crystal storing as histiocytosis, because the histiocytes are just going to clean up the debris and they just go and lie anywhere. Most often they get stuck in the gloms because of the filtration barrier, or they come out into the interstitium. Very important to remember that the tubules are affected due to cast nephropathy and light chain proximal tubulopathy. And the secondary changes that you can get happen due to in C3GN and thrombotic microangiopathy. Now, I've just referred to all this, so I'm not going to go into detail. This is just, again, for my junior colleagues, that there is, again, a very wide variation that you see in the clinical presentations, as well as some associated features like diabetes and NSAID intake. Under the microscope, the commonest disease associated with light chains that we find is cast nephropathy. You can also get significant number of amyloid deposits. In the past, we always thought it was only secondary disease that gave us amyloidosis. Not so anymore, because now our population is growing older and you'd also get significant number of amyloid associated with light chains. The others are rather rare, and so you don't get significant numbers. This was, of course, data that I had pulled out in 2020. So in these last 4 years, we have now accumulated a significant increase in light chain associated diseases. So I'm going to move on to the next group. And here you can see that there is again a lot of proliferation, a classic MPGN pattern, no loop patency maintained. So this patient is going to present to you with some degree of renal failure. And what we get strongly positive is IgG deposits along with C3. All of them are Congo red negative. And now we have this new stain, the DNA JB9, which is strongly positive. So I'm sorry, I'm just going to reduce this. Strongly positive in all patients of fibrillary GN, which has therefore definitely reduced the requirement for the electron microscope. But in some laboratories who do not have it, the EM does play a very important role. The reason to do the EM is to show the thickness of these fibrils, which could mimic the amyloid fibrils in toto unless you take the thickness. And as I mentioned to you, the amyloid fibrils move around the number 10, while these move around beyond 20, closer to 25. And you'll definitely therefore see that they are much thicker in width as compared to the amyloid deposits. Closely opposed also to them are the immunotactoid, which have a more of a tubular appearance with a small, denser area in the center. The cryoglobulins are relatively easy to detect at light microscopy. You can see these circular structures which are present over here, like over here in the lumen. Sometimes you're lucky and it's seen even in the bone marrow biopsy and at electron. And of course, you see it at immunofluorescence. Here you can see this was only lambda chain, kappa chains were negative, and the EM really highlights the presence of the cryoglobulins. And you can see a pattern of just large size tubules, which may not have any significant arrangements. Now, light chain proximal tubulopathy is a little tricky because we are so attuned to looking at the glomerulus. You see these far more often in the tubules as opposed to the glomeruli. And specifically, if you have caught them at light microscopy, it becomes even easier to identify them at electron microscopy. So you can see that this is a tubule because it has no foot processes at the periphery. It has the basement membrane, which is slightly thick. And in the center, you can see that there is an accumulation of some material. These could also be just clumped together red blood cells. But in the cytoplasm, you see some other structures which at high power, you can see that they are rod or needle-shaped structures. These are the crystals which have formed because of denaturing of the immunoglobulins or the light chains. Higher power view, just to show you that they may not all be this linear arrangement. They could also have this little cut, sort of polygonal or different shaped crystals that you start getting, which are present in the cytoplasm of the tubules. Rhomboid shaped is what they always talk about, but every time you may not have this classic rhomboid appearance. If, however, the tubules have been lucky and they have been spared of the deposits, sometimes because the histiocytes, mind you, are benign, they have just taken up the crystals into the cytoplasm, and then they are not capable of then functioning anymore, and they just remain behind for us pathologists to detect as having stored the crystals in the cytoplasm. Now, again, I have to show you a very similar pattern, which is called the MPGN pattern, which we saw in amyloid, which we saw in fibrillary GN. We're seeing it again in this second condition. And you will see that in this scenario, the PAS is very, very strong. Congo red stains are completely negative. You have a monoclonal deposition of kappa. And at electron microscopy, there is this very powdery material that gets deposited in the basement membranes closer to the endothelial cells. As you can see over here, you can see the foot processes here, you can see the foot processes here and here. And wherever you go, you will see this very powdery material, very electron dense, involving the lamina densa. It can also involve the vessel wall, and it can also involve the tubules. This was a patient who really taught us a lesson, because the first biopsy that had come to us came to us when the patient had already had a transplant and developed the lesion in his transplant kidney. We then discovered that he had been already biopsied by us in 2009 and pulled out those slides and saw that a feeling of deja vu, that am I seeing the same slide all over again? At that time, our immunofluorescence had not got any glomeruli, and we still were not adept at converting the the paraffin block to immunofluorescence. And we also couldn't convert the electron microscopy bit from, or rather process it from, the paraffin block. But when the poor gentleman came with a transplant lesion, by that time we did have the facility. And so we reprocessed it and found we had an identical picture at electron microscopy. So just to keep it in mind that monoclonal immunoglobulin deposition disease will recur in the transplant patient. Again, another MPGN pattern with so much of proliferation. This time, however, strong IgM deposits and lambda, no kappa. So this is an example of a diffuse proliferative glomerulonephritis with monoclonal immunoglobulin of lambda variant. Now, most often, these are the patients who will not come to you with full-blown malignancy in the form of myeloma or Waldenstrom's macroglobulinemia or a leukemia. These are the patients who invariably present to you with the MGUS or the MGRS pattern. I'm going to move on now to another patient. This patient was a full-blown case of myeloma, and these are the things that we saw at electron microscopy. We had deposits in the mesangium, few tiny deposits in the subendothelial region, and deposits at the periphery, that is subepithelial. You can see on higher power that there is this beautiful hump. There is a subendothelial deposit here and here. But what I want to bring to your notice is the deposit that is present in the basement membrane. C3GN is most often associated with deposits in the lamina densa. It does not mean that you may not get it in even a post-infectious disease, but if I had to put statistics in front of you, I would say that it definitely favors C3GN. Plus, you will see a slight variation in the intensity of the deposit. Here, the deposit is really dark, and you compare it to this and this, you'll find possibly these are slightly fainter than this. When you have this kind of a discrepancy, you should first eliminate a C3GN. Dense deposit disease, as everybody knows, very easy to recognize, involves virtually the whole lamina densa in a very linear fashion, ribbon-like fashion. And not only does it involve the glomeruli, it involves the Bowman's capsule. Here and here you can see, and it also spills onto the tubular basement membrane. Now, dense deposit disease can also be associated with monoclonal deposits. Likewise, TMAs, which show you this marked vacuolization of the lamina densa, swollen endothelial cells, as you can see over here, and complete, I cannot even see any lumen available here. And whatever lumen is seen over here is devoid of the endothelial fenestrae, earning the diagnosis of a TMA. So you have to remember that C3GN and TMAs occur. We still don't know why, but there have been a significant number of these patients who have had an associated monoclonal deposition of either the whole immunoglobulin or the light chains or heavy chains. And so there is a large amount of study that's going on, which is showing some sort of an association, but really the cause has not come out as yet. I'm moving on now from the gloms to the tubules. And of course, the prototype of involvement with the light chains is the cast nephropathy. And so you can see here that we have a tubule which has a cast. There is something very specific about this cast. Can you see this fissuring over here? This is one of the most specific facts that you have to look for, and they're known as fractured casts. Likewise, here you can see that it was possibly a cast which has now got fractured. And this is a PAS stain, and you can see how light the stain is, unlike your hyaline casts, which are bright pink at PAS staining. They also take a magenta red color on our Mason stain, telling me that these are entirely composed of light chains. Some of them may be Congo red positive, but they have a complete negative, no birefringence that you can see when you use the polarizing microscope. All of them will give you an answer about the monoclonality, either kappa or lambda. And I must warn you that the kidney can sometimes behave very erratically. The serum and the urine may show a particular type of light chain, and the kidney very rarely is known to show a different light chain presence. The explanation for this is almost unknown. 99% of the times, it will mimic the light chain that you see in the urine or in the serum. At electron microscopy, you do get conglomerates like this, which are very darkly staining. And when you go on high power, you'll see that they have the classic fibrillary appearance, which is the appearance of the light chains. There is a new discovery of a new electron microscopic disease, which has been associated with myeloma. And this is called as the infolding glomerulopathy. Most of the blame is taken by, the C3, and it's supposed to have happened due to a lot of deterioration of the C3. But what happens is that the food processes start moving into the lamina densa, like you're seeing over here. And when this is taken at cross section, it starts appearing to break down as small little spherules, which are possibly what are present in the cytoplasm. And this is infolding glomerulopathy, most often, of course, seen with the malignancies, that is myeloma, and not yet really seen with the MGRS group. And so I'm just going to summarize to you what are the features that you see in multiple myeloma. You can have cast nephropathy, which is, of course, the commonest, followed by amyloid, immunotactoid and fibrillary, and your crystal deposition. In Waldenstrom, it is commoner to find amyloid and cryoglobulins as compared to cast nephropathy and the other. And in CLL, it is invariably the cryoglobulins which give rise to all the damage in the kidney. However, other diseases are also known to occur in CLL, including minimal change disease. And we are all taught in histology that if you have minimal change disease after the age of 60, first exclude the presence of a CLL before you jump into a primary or disease of minimal change disease. I don't think I can stop ever any talk without giving credit to Professor Henry Bence-Jones, because it is because of him that the whole story started about monoclonal disease and specifically cast nephropathy. And this was his first patient referred to him by Dr. Solly way back in 1844, where he described the whole story. And this is the plasma cells that were finally found in this patient, but many years after.
Thank you, ma'am.
Yeah, Purva. So
It was the last slide will always be remembered. I mean, interesting. Thank you so much. I'd like to share this thing to go ahead. My slides, yeah. So, are my slides visible?
Yeah.
Thank you, ma'am. I'll just, before we move on to the panel discussion, I'll just bridge between pathology and the nephrologists and the oncologists. So ma'am has already summarized the differential diagnosis of nodular glomerulosclerosis. And this was like a favorite differential diagnosis question for us, wherein what is PAS positive, what is PAS negative, silver staining and Congo red. And as you can see here, the amyloid and the MIDD, the difference is that MIDDs are PAS positive and amyloid is PAS negative, and then Congo red is the completely opposite. Ma'am has already discussed this, so I wouldn't go in a lot of details about this, but this is the spectrum of kidney pathology in monoclonal gammopathy of renal significance. So for the panel discussion, we have ma'am, of course, and we have Dr. Mahesh Kota, sir, and Dr. Prakash Devde. Dr. Mahesh Kota is a nephrologist from Hyderabad, and Dr. Devde is an oncologist, hematologist from Aurangabad. Now, before we begin this panel discussion, I'll just have a brief background with what we do when we go ahead while testing for a case of suspected myeloma. So the most favorite is the myeloma panel, wherein serum protein electrophoresis, serum immunofixation, serum free light chain assay is always sent. And then 24-hour urine protein electrophoresis and immunofixation is quite cumbersome, but it completes the diagnosis. And this is an overview of everything that an oncologist and a nephrologist wants while concluding that this is the case of what entity in the spectrum of myeloma. Now, the International Myeloma Working Group has defined the myeloma spectrum in this form, that is MGUS, smoldering form of multiple myeloma, and active multiple myeloma. I won't go in much of details about the theory, but the difference between what I'd like to point out here is the difference between MGUS and MGRS is the presence of end organ damage. So in MGUS, that is monoclonal gammopathy of unknown significance, the M protein will be less than 3 grams. The bone marrow plasma cells will be less than 10%, but there will be no end organ damage. Whereas in MGRS, because there is renal damage, it is MGRS. And of course, even in smoldering multiple myeloma, there is no end organ damage. While in multiple myeloma, of course, there will be more than 10% plasma cells. Now, as a more pictorial form is the pre-malignant MGUS, the smoldering form, which then becomes malignant over the period of time. And we'd like to discuss the clinical aspect of this whole spectrum. Now, this is just an index case because we've learned a lot from this case. So this is a 54-year-old gentleman who had come with us from another village with a history of headache, altered sensorium, body ache, and he was wheelchair bound. He was not able to walk, and he had generalized weakness. He was treated elsewhere and had undergone 3 sessions of hemodialysis. And also he was labeled as CKD and a fistula was created. There was no evaluation done, probably because of the financial issues. On examination, when he presented to us, his blood pressure was 170 by 100, weight was 60 kgs, and his urine output was preserved, that is more than 2 liters per day. And his CT was suggestive of lytic lesions. That was the only pointer for us to dig deep and do the myeloma panel. And these are his labs. I'd like you all to focus on the 30th September labs, wherein you can see he had anemia, his creatinine was 7, and he had a calcium of 10 with serum albumin of 3.5 and proteinuria of around 5 grams. So during this period of time, we also got his free light chain assays done. And as you can see here, the free lambda light chain assay levels are around 4,800 and the ratio is 0.01, which is way below the normal. And M band was seen on serum protein electrophoresis. Now, this was his kidney biopsy, which was suggestive of cast nephropathy and this kappa, no, sorry, there was light lambda negativity and kappa deposits, that was 3+. This underlined part that you all can see is suggestive of the immunofluorescence. There is, I think, a typing error where they've written kappa light chains as negative, but there were 3+ kappa light chain deposits.
That must be in the glomerulus, which was negative. They've
Yeah.
specified
Yeah.
below.
Yeah. And this was the bone marrow. Unfortunately, we didn't get the number of percentage of plasma cells, but then it was labeled as suggestive of plasma dyscrasia. Now, what we did was in this whole situation was after the kidney biopsy was suggestive of MGRS or cast nephropathy. Not MGRS, I'm sorry, cast nephropathy. We started on therapeutic plasma exchanges. That is, after dialyzing him initially, bringing the creatinine down and he making him hemodynamically stable and bringing his HB up. We did 4 sessions of plasma exchange on alternate days with hemodialysis. 60 ml plasma per kg plasma was exchanged. After the plasma exchange, we started him on cyclophosphamide, which was given 500 milligrams every week, 3 doses. Bortezomib 2 milligrams every week, 3 doses. And dexamethasone 40 milligrams for 4 days per week initially, and then, followed by after cyclophosphamide and bortezomib. And what we saw was this trend in his free light chain assays, which you can see in December, his kappa lambda light chains had come down to 11.73, 12.98 respectively. And even the free kappa lambda ratio was almost near normal. Now, over the period of time, after he completed around 8 cycles, it was almost January. And now we didn't know what to do as nephrologists because he is in remission as far as the kidneys are concerned. Because as you can see here, his creatinine had also come down to 1.7 and there was no proteinuria. So we had referred him to an oncologist. and he had advised doing cytogenetic testing and also consider bone marrow transplantation as a cure for the disease. But unfortunately, the patient didn't opt for bone marrow transplantation. And this is him after the treatment where he could walk and he was off dialysis. Now, the issue with this patient was that after being advised to undergo bone marrow transplantation, which he didn't opt for, he was back on dialysis, say around 6 to 9 months later after being in remission. And he probably died later. That's what I received the news as. But so the dilemmas that we learned from this case was that what to do once renal remission is achieved. Whether you keep continuing chemotherapy, you give them some anti-proliferative agents, or you do bone marrow transplant right away. And when do we plan bone marrow transplant in such cases? So for this panel discussion, I'd like to invite Dr. Mahesh Kota and Dr. Prakash Devde. And it's the dais is open for everybody to ask questions to ma'am also. Now, I'd first ask questions to the oncologists because I think their perspective and their approach is slightly different from how nephrologists approach the cases of myeloma. So, Prakash sir, are you there?
Yes, yes. Sorry for there is problem with my video. So, bear with me.
No problems.
So,
I'll just go with the questions one by one because although they are all there on the screen, but I'll just go one by one. So the first question is, sir, with this as a reference case, are there any treatment defining diagnostic tests which guide the physician to choose a particular regimen over other? And for example, like everybody is doing cytogenetics, and they are seeing these defects like deletion of 17p translocation. So these high risk tests, do they warrant treating with a more aggressive regimen versus a more less aggressive regimen?
so you are asking in general, not pertaining
Yes,
to
yes.
this case.
Yes, sir, yes.
So, in general, of course, there are treatment defining diagnostic tests. It's the most important is the FISH panel. So, we do in each and every case the FISH panel because there are high risk cytogenetics and standard risk cytogenetics, and the treatment differ. So, for high risk, as you said earlier, warrant treating with more aggressive agent. That's right, because if it is a high risk, like what the cytogenist here is mentioned, so we have to treat with the quadruple regimen. That is combination of daratumumab and bortezomib, lenalidomide, and dexamethasone. So 4-drug regimen usually what we give in high risk cases. Where there is a standard risk cytogenetics, if it is there, of course, we can give triple drug regimen, even double drug regimen like Lendex in frail patients. And again, the choosing whether there is a early HCT or delayed HCT also, it depends on if it is a high risk, we prefer going for early BMT. Whether if it is a standard risk, we may delay or we do bone marrow transplant at first relapse. So we need aggressive regimen for high risk. So there are other tests also, free light chain. If there is a load is higher, we may choose the aggressive regimen. And there are other treatment defining, we can say PET scan is also there, burden of the disease.
Right. Sir, is bone marrow advisable even if the patient achieves remission?
Remission for myeloma profile, you are saying?
Yes.
Yes, yes. So even if myeloma profile is normal or there is a stringency or bone marrow is usually done to document if there is a, we are not doing in MRD, but at least if there is a good remission in control disease in the bone marrow, the bone marrow transplant is actually done. Uh, it should be in at least very good partial remission or good remission. That's where we do auto BMT.
Right. So, for instance, like in kidney disease transplant, kidney transplants, we usually do transplants where they're fairly in a controlled state, like they don't have any fluid overload, they're not infected, and they're undergoing routine dialysis, and no such acute event has happened, or those are prevented prior to transplant. Similarly, is there anything where we can deem fit for bone marrow transplant, or we can start going for bone marrow transplant at the diagnosis itself?
So for renal patient, you are saying presented with
in
ARF or
in the spectrum, let's say we have MGRS, and then we've also, like, there are patients who first come to a nephrologist who are found to have MGRS, and then eventually when they get a bone marrow, there are like in this case there are obvious
I think in MGRS bone marrow is not done, no?
it's
Because
not done. But so for a holistic approach, wherein if you are finding MGRS, it is always advisable that you do check for end organ damage wherein the marrow is involved or not.
I think MGRS there is no will do bone marrow because it's after we do all the tests. It is MGRS. There is no other like skeletal survey or PET scan is normal. So there will not be any role of bone marrow in those cases. They are usually for high risk cytogenetics or in multiple myeloma cases, not in solitary plasmacytoma, smoldering myeloma, or MGRS.
Okay. Okay.
Sorry,
And in
Dr.
the
Devde, I'm sorry, I'm interrupting Dr. Devde, but sometimes, if the levels of proteinuria involvement are little on borderline, then people do get worried and they do the bone marrow to try and show that the number of plasma cells are less than, 10
Yes,
to.
we have to monitor, of course. If there is
Yes.
a
Yeah,
for
that
MGRS to turn into other
I know. I'm sorry, I
myeloma.
shouldn't be talking. I'm
I
not a treating person, but
I,
happen
I
to.
completely agree with Dr. Sheila because the proteinuria is determined by the GFR. So if somebody has a very lower GFR, we may not get that much of proteinuria.
Yeah.
So sometimes people like me end up doing a biopsy because we don't believe that proteinuria corresponds to that GFR. So probably in some cases we are justified in doing a bone marrow, even if it is an MGR. That is like my opinion.
In fact, to confirm that it is only MGRS, bone marrow always gives you a good indicator.
So the
Yeah,
other
I
way
concur. I concur.
around is if there is multiple myeloma, like this is what discussion we had prior to the panel this webinar, is if there is multiple myeloma, should we do a kidney biopsy also?
If there is no renal involvement,
Right.
there is no need of renal biopsy.
Right. But sir, sometimes
I may partially disagree with you, sir, because we do renal biopsies in either multiple myeloma or amyloidosis, or if there is any abnormal protein. We have a significant amount of renal injury just because of the proteinuria, as Dr. Girish sir said. And this proteinuria can ultimately leads to overall interstitial fibrosis of tubular atrophy, chronic interstitial fibrosis, or at the same time this the protein which is entering to the tubule can cause some amount of cast nephropathy or light chain deposition disease, which may prognosticate the patient from kidney perspective. They are not definitely done to diagnose the cause of what is the baseline paraproteinemia, but to see the extent of kidney involvement and to see the type of kidney involvement, I think we may offer biopsies as a nephrologist for that particular reasons.
So to find out subclinical disease, you are saying, and
Not
your
subclinical. Not subclinical disease, sir. Definitely, even though the creatinine is normal, the patient might be having some amount of chronicity, which we cannot explain just by serum creatinine as a biomarker at that point of time. We definitely want to know what is the extent of what is. We know that suppose if the patient has suppose a multiple myeloma, there are Dr. Shaila has enlisted so many histological findings in the kidney. Among them, commonly that what we see is interstitial nephritis and gas nephropathy. Sometimes we may see light chain deposition disease. Sometimes we may see amyloid changes. But without having a biopsy, we cannot get into conclusion what is the lesion in the kidney. It may be a little bit difficult for oncology point from oncology point of view if we offer a renal biopsy for a normal kidney function. But if we see some amount of proteinuria, definitely we will offer a biopsy and we will definitely have differential diagnosis. And at the same time, the extent of kidney injury is also very important. The patient might be having serum creatinine between 1 to 1.3, which may look normal for a non-nephrologist. But if we do biopsy for that particular patients, we can see the chronicity of around 25% or 30%, which may definitely give prognostic information, and which may even think about the further step, like in the sense when this patient is going to have any end stage renal disease, or should we offer him combined bone marrow transplant and the sense renal transplant, or if the patient, if he is undergoing bone marrow transplant in future, this particular patient might land up in end stage renal disease. The examples that I'm going to tell in my when I am coming into the picture in this discussion. I think Girish sir also can comment regarding this if he's.
Yeah, absolutely. I mean, the kidney involvement not only affects the overall management plan, but it would definitely affect the prognosis. So I think proteinuria of say even more than say 500 milligrams could prompt us for a biopsy.
In fact, most data does mention that you have to have the biopsy done the
Yes, ma'am.
moment if in a known
Yeah.
case of myeloma. If you didn't know it was myeloma, it's a different
Yes,
matter. But
because
500 milligrams is really the cutoff, and the eventual prognosis is directly proportional to what you find on histology. And very often biopsies are not done just for diagnosis. You know the diagnosis already, but you want to know the prognosis and also the treatment options, because your treatment is also going to give rise to a lot of issues. So whether,
yes,
you are,
madam. If we go back to your index case, the first slide you
yes,
started,
precisely.
precisely that patient. Sometimes, if we go back to my MD days when we don't have a significant knowledge in paraproteinemia or renal injury, we would always treat on outpatient basis for someone with creatinine of 1.5 to 1.7, and we rarely look into 24-hour urine protein quantification. We just see complete urine examination, and if it is 2 plus or 3 plus, and if there is no edema for that particular patient, we just give some treatment for hypertension, we may send them. But ultimately, if we lose that viable period, and if we don't do biopsy, and if we don't pick up a diagnosis, by the time the patient comes to a nephrologist or oncologist, his creatinine might jump from 1.6 to 1.8, but the chronicity will be definitely very high for that patient.
Absolutely.
Right.
So
Just
just last question, is there a recommendation to do kidney biopsy if renal function there is normal, no proteinuria or no renal any issues are there?
Sir,
So
if as your question is very clear and straightforward, sir. If the renal function is normal, if there is no proteinuria, then we don't offer a kidney biopsy.
yes,
There's
that would
nothing
be the
that we can say.
consensus. That should be the consensus.
Yes, you just say, for example, we take an example. If a patient comes to a medical oncology department with for any unexplained body pains, and if you suspect paraproteinemia or multiple myeloma, and if you have sent all the relevant investigation, and if you have found significant serum free light chain elevation, but if the patient doesn't have proteinuria and if the patient creatinine is absolutely normal, then they think at this point of time the guideline says don't go and jump and do a kidney biopsy. And at the same time, I would also agree for the fact that if there is no proteinuria and if the renal function is normal, if you have a straightforward diagnosis with serum free light chain elevation, then definitely yes, we can avoid biopsy. But from a pathologist point of view, I don't know whether this will be turning up into amyloid or a light chain deposition disease or a heavy chain deposition disease. That I'm not sure, because there could be multiple variants in the sense the same myeloma can turn into an amyloid, the same myeloma can turn into a light chain deposition disease. But I would ask Shaila madam to comment on this, whether we can pick up any other biopsy apart from kidney biopsy. Should we do any other fat pad biopsy, or to see if there is any change in the presentation of the disease?
Sorry, you're asking me whether to decide whether the patient has amyloidosis, whether it
Yeah,
makes
why
abundant sense.
because madam, we have a similar one case we addressed for in fact I remember it in December somewhere. This patient has a frank paraproteinemia. The patient has no renal failure, but he has subnephrotic proteinuria, some 1 gram proteinuria. But the patient was having pancytopenia. His platelet count was 50,000 or less than 45,000. He has severe anemia, and he has elevated TLC. And during the course of his hospital stay, he developed sepsis and he landed up in fulminant septic shock and he was on ventilator. We want to know whether is there any amyloidosis element for this patient. If we can do a kidney biopsy, we can definitely check for congruent staining, and that story goes in a different way. Then the discussion came with our hemato-oncologist, and he was offering to do a abdominal fat pad biopsy to see if there is any amyloidosis. Similar, that's what I just want to know.
Yes. So, well, we are also getting a lot of, fat biopsies, the fat pad biopsies. But I must say that the yield for diagnosing amyloid is very low in the in the abdominal fat pad biopsies, and likewise in the rectal biopsies. I do not have too many cases where I can be 100% certain. In fact, I've got very occasional cases where the amyloid deposits are seen in the fat pad. So I don't know whether it is a situation where, we are not going into the right area because we don't know, we don't have any, modality to understand which is the area we should be biopsying. Unlike the kidney, which is fairly diffusely involved. So even if you get a glomerulus, you can still give a diagnosis. So I feel maybe that is the issue. And I think that's what's mentioned in literature also.
Yes.
That
So then we can, Prakash sir, then we can take it for granted that we will offer kidney biopsy, not to see the lesion in the kidney. To have a systemic diagnosis, renal biopsy can be a operating tool. I think.
Sorry, and I think the combination of a good amount of glomerular origin proteinuria, which is, of course, the baseline being more than 500 milligrams, and hypertension should point you in the direction 100% of doing a biopsy, because amyloid is the first thing on the card in a patient who has excess light chains, either urine or serum. Corrected, of course, for the GFR, like you mentioned.
Right. So I will go ahead with the next question because we have a lot of more questions left. So Prakash sir, how frequently should one monitor response to treatment for patients in various stages of myeloma? And also if BMT is not done, like if transplant is not done, like in this case, how frequently should the patient be reviewed for the remission status?
For multiple myeloma, we do free light chain assay and serum protein electrophoresis each cycle. And if there is a continued response, we can do alternate cycle for multiple myeloma. So in other myeloma spectrum, that is solitary plasmacytoma or smoldering myeloma, solitary, we usually do radiation, and after 3-4 months of radiation, we do PET scan to whether there is a remission or partial response is there. And later, say, we do every 6 months that serum protein electrophoresis, free light chain assay, and every like 6 month or then yearly for imaging. So smoldering myeloma, there also we have to check this myeloma profile more frequently, every 3 to 6 months early initially, and then every 6 months, and yearly imaging is done. Second question here also, if BMT is not done, how frequent okay. So if BMT is not done, patient will be on maintenance. So on maintenance, again, as the trend is there, patient's symptoms. So if there are suspicion of progression, then we do all myeloma profile with PET scan. But if there is a continued response, uh, we will check again with free light chain assay more frequently, or 3 monthly free light chain assay is recommended on maintenance.
Right. So the next question is, I would want to actually ask, like, what maintenance therapy is this the same cycle that you keep repeating, but at the like a larger intervals?
So for high risk cytogenetics, usually we give double maintenance, that is usually lenalidomide with bortezomib if it is a part of previous regimen, or lenalidomide daratumab is usually for high risk cytogenetics. Maintenance is there if patient even for gone for BMT or not gone. But if it is a standard risk, then single agent lenalidomide maintenance is the standard for maintenance.
Okay. Sir, is CAR T therapy or bispecific antibodies improve renal function in myeloma patients with kidney involvement?
So in general concept is, if there is a control of myeloma, then of course there will be improvement of renal function. So I can say CAR T cell therapy or these bispecific antibodies which are used in second line and beyond, they may improve renal function with kidney involvement.
Right. Sir, before we go to the last question, there's Dr. Chaudhary who is asking, can multiple myeloma occur without anemia and kidney involvement?
Okay, I'm seeing the question. Can multiple occur without anemia and kidney involvement? Yes. Myeloma, if there is more than 10% plasma cells in bone marrow, and any of the CRAB feature is there, like hypercalcemia, anemia. So all abnormalities usually not present in every case. So without anemia and without kidney involvement, and actually I'm not seeing kidney involvement much in these days. So usually can say that they like present early. So myeloma can occur without anemia kidney.
Right. Sir, and how does early versus delayed autologous stem cell transplant affect kidney recovery in myeloma patients? And in case we have
Mm,
to do dual transplant,
so
that is bone marrow and kidney,
okay.
can you just tell us about
So
the technicalities?
okay. So early versus delayed, as I said, in for high risk cytogenesis, we do early BMT, but it for kidney with kidney involvement, then early would be better, because if there is a stringent CR or CR at bone marrow or for myeloma, and so of course there will be less chance of paraproteinemia, and kidney recovery will be good if for early auto BMT. So early would be better for kidney recovery. And in case of you're saying bone marrow transplant plus kidney transplant, both
Yes,
together.
yes. Like the
So in
technicality,
general,
what I mean is, we usually give baseline immunosuppression and induction agents and things like that. So in bone marrow transplant, there must be some induction agent and then some maintenance or how is it like? Because we have to do two things at the same time.
Okay. So first thing, the obvious thing is we cannot go for kidney transplant if there is a disease, myeloma is not in remission.
Yes.
So in general, there are very few cases or case series where both bone marrow transplant and kidney transplant has been done together. So bone marrow, there is at least a very good partial response at myeloma is there, and along with that, kidney transplant has been done, and there are like responses are there, there are durable remissions are there. But in general, if want to do which should be done first, of course, bone marrow transplant will be the first, because we want a disease to be remission, then only kidney transplant has value. So in general, if there is a stringency here in bone marrow, then we can plan kidney transplant later. So if you want to club together, you can do, but if there is a technical issue, then bone marrow transplant first, followed by kidney transplant.
Right. With that, thank you, sir. There are more questions in the chat box. I'd like you to please answer them. I'll
Okay,
go.
I'll write the answers.
Next panelist, Dr. Mahesh, sir. Since ours is a slightly biased nephrology forum, so we've got a lot of questions for you. A patient with
Thanks.
incidental end-stage renal disease. We had one female who had come to us. She had no prior diagnosis of myeloma whatsoever, and she had come with creatinine of 14, and she was dialysis dependent. And serology was suggestive of M band, high free light chain assay. How would you approach this situation, given that the patient is dialysis dependent?
Yeah, so that was a nice question. Actually, we have two patients. We have an experience of the two patients. Both of them, one of the patient is our patient, one patient is from other unit. So our patient who had an end-stage renal disease, which was not biopsied prior to the, which we could not do any biopsy before we see the patient. We saw the patient in end-stage renal disease, and we put the patient on hemodialysis. And after a couple of months, we encouraged him to go for a transplant. And post-transplant, he was doing well for 1.5 years. And after 1.5 years, he had an acute kidney injury. His serum creatinine was elevated. And we did a graft biopsy, and the graft biopsy was showing light chain deposition disease. And the graft, I think Girish sir was also there at that point of time along with me. And we referred the patient to a hemato-oncologist, and based upon the finding that that what we had light chain deposition disease, he was worked up for paraproteinemia, and he was found to have multiple myeloma. That means that patient might be having multiple myeloma prior to the insult, which was not manifested apart from kidneys. That means the manifestation of multiple myeloma for that patient was only renal failure, which was not missed at that point because we could not do biopsy. He presented with end-stage renal disease. Apparently, by God's grace, his platelet count, everything was normal, but his creatinine, his kidneys was shrunken in size. We could not do biopsies, and we thought it was a chronic interstitial nephritis. So for that patient, he was subjected to chemotherapy with Cyborg regimen, and he was doing well. And now he is in remission. This is that one particular patient. The other patient that what we had is this patient is a software engineer, and she had a unexplained end-stage renal disease, but she was subjected to biopsy. But I don't know how somehow light chain deposition disease was missed for her when she underwent a biopsy, which was done in Bangalore. And she presented to, she was subjected to bone marrow renal transplantation with her husband being donor. And after renal transplantation surgery, again she had an event of unexplained pancytopenia and with unexplained bony pains. And with this background history, she came to the hospital, Basavatarkam Cancer Hospital in Hyderabad, where she was subjected to routine analysis, and she was found to have significant paraproteinemia. and she was also started on same chemotherapy, and both of them doing well. I mean, the first patient where we have diagnosed, and the other patient with the other SAM unit. I think if the patient has an end-stage renal disease suggestive of an M-band with a high free light chain assay, first at that point of time, if we are very clear that if this patient is not going for a renal transplantation surgery at that point of time, and at the same time, if we found that the patient has elevated free light chain, I would refer the patient to an oncologist to first keep the disease in remission. Because if we do not keep the malignant multiple myeloma in remission, even though if we do a transplant, that kidney will be affected immediately with the significant high free light chain. So definitely, as Dr. Prakash has said, if there is an event like the patient, we have diagnosed to the patient to have an end-stage renal disease, at the same time the cause for renal dysfunction is multiple myeloma, treat the multiple myeloma first. Go keep the disease in remission by whatever the method, whether you do a chemotherapy or you offer a bone marrow transplant. Then if once the disease is in remission, then go for a kidney transplant later.
Right. So I think the age group of these patients also must be around above 50.
One that lady was a very young lady, young in the sense like if I remember, it is 38 that years.
Okay.
The other gentleman was 65-year-old gentleman.
Right. Okay. So does like the way we in this situation in our patient we did plasma exchange, but he was presumed to be a CKD and his diagnosis was not done. So in this situation, like or in general, does early initiation of plasma exchange or high cutoff dialysis improve renal outcomes in myeloma kidney?
So this is a very tricky question that you have asked, Purva. So when I was in, when we both of, I think both of us are contemporaries. When we were in 2017, when I was a first year nephrology resident, whenever I see a patient with multiple myeloma, my brain will be blank. I don't know what to do. Then when I take the report to my boss, he would say, work up, do a biopsy, see the chronicity in the kidney, and at the same time take an opinion from oncologist. And at that point of time, oncologist, only two words we can see: high dose of dexamethasone, bortezomib. Apart from that, I don't know how to give anything. But when we finished nephrology, when we started practicing our nephrology in the cancer hospital, at the initial point of time, there was no particular consensus. Like both me and oncologist were agreed to do plasmapheresis, because we remember so many cases. We diagnosed the patient to have multiple myeloma. Straight away we do plasmapheresis, and the high cutoff filter. At that point of time, we don't have an experience about theralite filter, which is very costly in India. At the same time, when we finished our exams, both ULITE and MyRe trial was released, and we found that there is no major significant difference with high cut of dialysis, and which was compared with Cybo-D regimen or doxorubicin. So we did plasmapheresis, and from my side and from oncology side, the patient was started on chemotherapy. Patient was doing well. After 2 to 3 years, when we see these group of patients, I think I have asked Girish sir also, sir, when you do so many plasmapheresis, patient initially doesn't have any edema, but over of late, after doing some plasmapheresis, why the patient is developing edema? Then we came to a conclusion that the viscosity of the patient is very high, and which prevents the patient to develop edema initially. But over a period of time, when we do plasmapheresis, when we remove the light chains, when the viscosity is lost, the patient definitely has very low albumin in the body, and it leads to an edema. But this is apart from the story, where we came to a conclusion that why to do plasmapheresis when we are able to reduce the free light chain easily by just giving high dose dexamethasone and bortezomib. Why we want to trouble the patient, unless otherwise if the patient has significant renal failure, if we are not doing plasma. But this has changed in the last 3 months only. Now we are seeing patients with serum creatinine of 9 diagnosed to have multiple myeloma. And my oncologist, Dr. Pavan, in hemato-oncologist, Dr. Pavan in Basotarkam, he said, why don't we do plasma like that? When we go back to literature, Why this high cutoff filters or plasmapheresis initially was not effective? If we see clearly, this free light chains has very high volume of distribution. If you do a plasma, the next minute it gets accumulated into the patient bloodstream. If you are trying to remove with a high cutoff membrane, again it gets accumulated in the patient bloodstream. But if you give a drug like the high dose dexamethasone or bortezomib, which doesn't depend upon the volume of distribution of these free light chains, and it show its beneficial effects definitely. But if we want to do a plasma, now we are doing almost 5 liters, 6 liters of plasma daily. You can imagine only with a serum creatinine of 9, I own my that is the only indication that I can push my oncologist to do a dialysis. With one dialysis, definitely the patient acidosis level subsides, calcium subsides. But daily, my oncologist is doing for 5 days, 5 to 6 liters of plasma will be exchanged for 5 days. You can imagine patient was going to home with creatinine of 2 or 3, but he is not being dialyzed later. But at the same time, he was started on chemotherapy also. So this type of treatment will definitely keeps on changing from for every 2 to 3 years. Now at this point of time, I am convinced by the data that what my oncologist has shown to me, and at the same time, when I also think about when we are doing plasma pheresis, just by doing one plasma volume or two plasma volume, it doesn't affect the patient. If you want to remove all the free light chain which is unnecessarily present in the patient body, do 5 to 6 liters carefully with the centrifuge based method, and do it for every consecutively every day for 5 consecutive days. I think the load will be definitely decreased, and we know that each and every organ damage that occurs in the multiple myeloma will be dependent upon the high free light chain. If we can decrease it by any method, the patient will be saved. So I would agree with the early initiation of high volume plasmapheresis. Yes, high cutoff dialysis may improve, but the filter cost is very high, so we are not able to do that in our centers.
So related to this, in PGNMID, that is proliferative glomerulonephritis monoclonal
Mm.
immunoglobulin deposit disease, with less than 10% plasma cells on bone marrow, should the
Mm.
patient be treated with anti-proliferative agents, or we give bortezomib based?
I think I would, based on the nephrology knowledge that what I have, if the patient is having PGN MID, first the only thing that I would see is whether it is plasma dependent or lymphocyte predominant. Plasma site predominant or lymphocyte predominant. If it is lymphocyte predominant, I would go for rituximab. If it is plasma predominant, I mean plasma cell predominant, as you suggested, you can go for cyclophosphamide, bortezomib, and high dose steroids. But I think apart from me, oncologist Prakash sir can tell better answer for that. In PGN MID with less than 10% plasma cells,
But
I think
that lesion will probably not be seen by oncologists.
no, PGN MID you said less than 10% on bone marrow. So at that point of time, from nephrology point of sight, we will always see what is happening inside the kidney. What is the renal function? What is the proteinuria? What is the chronicity? That goes in one side. The other side is whether to offer what type of chemotherapy. Whether if it is in proliferative glomerulonephritis, whether it is predominantly plasmacyte dominant or lymphocyte predominant, that will be a decision to offer anti-proliferative agents. And honestly to say, my experience in the entire 7 years of my nephrology have seen only 2 cases of PGN MID. So I think my comment in this may not be a good value. That's what I can do.
We
Or
have
at the
one patient.
or we can take people, many nephrologists in this platform. They can also comment in this area.
So we had one patient.
Because
She
with one or two case reports, I cannot get into any
yeah.
conclusion.
Yes.
So, Purva, most often the proliferative disease with monoclonal immunoglobulin deposition is associated with a CLL. You almost unheard of having it with multiple myeloma or Waldenstrom. And so, therefore, that has to be weighed by the oncologist as to whether the CLL needs to be
Yes.
looked into
Yeah,
before.
yeah.
And of
Either
course,
yes.
sorry. And then, of course, you have to look at the renal function and take a call accordingly. So you can't be like,
Yeah. it's a team decision, madam. See,
Yeah.
we cannot see, we cannot as I think, if even if though if you are a very good nephrologist, if you are staying alone, if you see a typical
फिर उसको तो बाहर रखना पड़ेगा.
Yeah, so go ahead, please.
Yeah, I
Hello.
think Dr. Kota, there was just a disturbance. So
Okay.
what you were saying is,
So that's what, madam. It's definitely a team decision.
yeah,
What one person cannot definitely take a hand with very rare cases.
So coming to the last question, we've exceeded our time, but I think that's the beauty of good discussions. What are prerequisites before proceeding for kidney transplant in end stage? Due to now, obviously, many a times we don't know what is the native kidney disease. But if in case you have an MGRS or a myeloma, this is just for it is there in the textbooks, but just for wrapping up the session. How long do
So
we wait, and what is the
so
fit?
so
For
if you, I think we have similar kind of discussion happened just a couple of minutes ago, madam. So if we have a patient with end-stage renal disease, and if we from our side and from oncology point of view, if you have found any element like MGRS or multiple myeloma, first, definitely, without knowing the exact lesion, I would not jump into do a transplantation surgery. That means whether it one of I think one of the examples that Shaila madam, the index case is that is turned out to be an amyloidosis. So without having, I mean, in the sense, if you classify the MGRS, we know there are multiple diseases. It can be an amyloidosis, it can be fibrillary glomerulonephritis, it can be immunotactoid, or it can be cryoglobulinemia, anything if it is MGRS. If your question doesn't have that bar and multiple myeloma, my answer would be very easy. First, find the reason for MGRS and proceed. If you are dealing with purely multiple myeloma, if you are very clear, just ensure that the patient is in remission from that point at that point of time. If the patient is not in remission from multiple myeloma, or it can be an amyloid, or it can be a light chain deposition disease, or fibrillary or immunotactoid, do not jump and do a renal transplant, because the graft will be damaged immediately with the primary disease. Definitely, if it is a multiple myeloma or MGRS, first treat it, allow the to go into remission, and then go for a renal transplant. As a part of treatment for that primary disease, suppose for multiple myeloma, if you have done an autologous stem cell transplant, you can choose a donor based upon the requirement. But if the donor is if it is an allogenic allo transplant from hematological point of view, I would encourage to take the graft from the same patient, because the antigens will already be sensitized, and graft accommodation will be much easier if you use the same donor at that point of time.
Right.
sorry, Purva, one thing is very clear that monoclonal immunoglobulin deposition disease, you have to be very, very, very particular before you start transplanting.
Transplant, yes.
You're going to lose that kidney again. So you
Again.
really have to be sure
Yeah.
that your primary disease is looked
Yeah.
after
So
well.
why? Because if the patient lose graft from a hematological point of view, nothing will happen.
That
You
is
know, if you lose a kidney, I think you know what you are going to face with the in front of patient.
I mean,
So
I understand and I know what you go through, but irrespective, I mean, you don't want that number on
I think
your
with the
shoulder.
advent of so many investigations, like you have already highlighted that in 2009, the patient had end-stage renal disease and then transplant was done and then there was a recurrence. So there's a
Yeah.
drastic difference between the timeline also, probably because of which,
yes, madam. See,
now there is no
and
excuse. There
and
is no
and,
excuse
and
diagnosis.
one more thing we should tell to the, suppose if the patient had a multiple myeloma, he was treated by chemotherapy, underwent into remission. Of late, if he developed end-stage renal disease, if he is going for a kidney transplant surgery, we should. I know, Purva, you will be before any renal transplantation surgery, you will be having a family meeting and you will be telling about the reoccurrence of the disease. Because for apart from multiple myeloma, if either it can be MCD, FSGS, or membranous, you will tell these are the percentage of the patients where the graft will be functioning for so much time, and there is a chance of reoccurrence. And here, if we are dealing with MGRS or multiple myeloma, we should tell the recipient and family members that this particular disease is going to reoccur. It may be having multiple episodes of remissions and relapses may happen. If he had a bad relapse, this graft will be at the risk, definitely. So we should tell the patient about the disease course of multiple myeloma or MGRS, then only go for renal transplantation. Because this patient doesn't had a kidney disease in prior. Every problem started with multiple myeloma, and if he is going for a renal transplantation surgery, he will forget what are all the things happened to him prior to the renal transplantation surgery. He will only ask whether why my graft is losing, why I'm losing the graft, why my multiple myeloma is again getting multiple relapses. Are there any drugs to prevent the relapse? All these questions comes into picture. So we should be very clear what are the what is the bad protein we are dealing with, and what is the primary element of I mean, in the sense, what is the type of MGRS we are dealing with, then only proceed for transplant.
Right. So with that, we come to an end. Thank you so much.
Sir, any experience of kidney transplant in myeloma patients?
Yes, sir. Yes, sir. We had two transplant patients, but I cannot tell those examples because both of the patients are treated by chemotherapy. They did not undergo autologous stem cell transplant or allogenic stem cell transplant.
There
Both
was
of
one.
them.
Yeah, please.
Yeah, those were on maintenance and then
Yes,
again
sir. Yes, sir. Now we have
on and
one
off
very,
therapies.
yes, sir. We have a patient from Nanded. So he was diagnosed to have multiple myeloma in 2022. So in 2022, he underwent a chemotherapy, but at that point of time, his creatinine was 7 or 8. He was on dialysis for a couple of days, and his renal function started improving when his light chain got decreased by chemotherapy. But I think he lost significant amount of renal functional reserve. Now, after 2 years, he reached end-stage renal disease, and he was worked up, and we discussed all the pros and cons about renal transplant in multiple myeloma remission. And as of now, he is in remission from multiple myeloma, and his graft is functioning well. But we are very clear that we don't know when he will get a relapse from multiple myeloma, and we explained the family and the patient that if he had a relapse from multiple myeloma, similarly like how a native kidney is affected, the graft will also be affected. So, but I hope, touchwood, he should not go into that situation.
Yes. Thank you, sir. Thank you so much. Thank you, ma'am. It has been a wonderful discussion. Just speak for the next this thing. We are also going to be discussing amyloidosis in the next webinar.